Greetings and welcome to this video on dimorphic fungi. In this antifungal series, we'll discuss about the drugs that are used to treat the dimorphic fungi. So, we have already done 6 to 7 episodes on this antifungal modules. If you have not watched those, please have a look on that in the playlist Antifungals. Let's get started. So, therapeutic philosophy is that mucorales are pretty chaotic and doesn't respond to normal antifungals such as echinocandins or azoles. So whereas Aspergillus is you have to use precision warfare with Oriconazole. Specific azoles are that are sensitive for Aspergillus, and for dimorphics, it is often the long-term treatment with common antifungal drugs such as azoles. So antifungals here behave nicely and actually predictable because dimorphics exist in the environment as molds, whereas inside the body it acts as yeast. That's why it's called dimorphic fungi. So the change of form in humans, the thermal switch is the single idea that explains everything that is present for this antifungal therapy for dimorphic organisms. So for environment, it exists as mold, that is at cold 25 degrees Celsius. It acts as mold, and inside the human tissue. At 37 degrees Celsius, it exists as yeast. So, because of this, it has reduced invasiveness compared to mucorales and slower growth compared to mucorales and less ergosterol dependence for its replication. So ergosterol dependence makes it an ideal bug that can be treated with an azole group of antifungal. So the biology drives the drug response. So yeast based reality. So unicellular yeast like in tissue, it grows very slowly with metabolic lag, depends heavily on ergosterol and disseminated via macrophages and not the blood vessels. So in all these features have the good clinical implication for treatment for dimorphic organisms such as fungistatic drugs become effective. Even the cell wall targets are actually unnecessary. There is no role for amphotericin B or echinocandins. So long-term oral therapy has actually works. Azole dominates the treatment in this aspect. So the big three, so biological feature is that intracellular, it survives intracellularly inside the macrophages. So it needs prolonged therapy because it lies inside the macrophages, needs prolonged therapy with azoles and slow replication. So fungistatic drugs azoles are very much sufficient. Ergosterol dependence makes azoles highly effective drug and chronic dissemination. So long duration of therapy is very much mandatory for these dimorphic organisms. So examples of this group of dimorphic fungi are histoplasma, blastomyces, and coccidioids, as you have already known. Why azoles are backbone? Because excellent penetration, reach intracellular sanctuaries even within macrophages, stable long-term use, which is low toxicity profile for months and long courses. Focus on the ergosterol dependence of the yeast phase with slow relapse rate when given adequately, and outcomes are very much superior. So azoles are the backbone therapy for dimorphic organisms. So it is just like the opposite of mycorrhiza's management, where you give amphotericin B and Echinocandins if sensitive. So for mild, moderate, stable, non-CNS disease, azoles only is the treatment. Situational role, induction versus maintenance. So amphotericin can be used in situation when severe load reduction is needed. So when you don't know the fungus, probably whether it is a yeast or a mold, then at that time you can go for amphotericin B initially. When you suspect a severe disseminated infection, when the vitals are unstable, and there is CNS involvement and immunocompromised hosts. In all these cases, amphotericins are the indications. Therapeutic curve from high burden to maintenance. So in this case, high burden, you can go for amphotericin. For long-term maintenance, you can go for azoles. This is situational role only, but most cases, and fungal azoles will be more than sufficient. So echinocandins, talking about echinocandins, so conazole, posaconazole, these group of drugs are very much sensitive, whereas caspofungin, micafungin, and inulafungin, which are the echinocandins, have 0% role for this dimorphic fungi because they do not rely heavily on beta glucan. So yeast phase wall differs from the water in candida. Intracellular localization limits the drug access also. So thus echinocandins completely fail. So it is because of the lack of a biological logic rather than lack of data, echinocandins are not used for dimorphic fungi. So this is the basic overview. Dimorphic fungi such as Cryptococcus species, Histoplasmosis, blastomyces, and coccidioids. All these are very much responsive to azoles, fluconazole, oriconazole, isoconazole. And for echinocandins, there is literally no role. For amphotericin B, all responds to amphotericin B also. So drug of choice remains azoles, either isoconazole, posaconazole, voriconazole, or fluconazole. Fluconazole, plus or minus, you have to know the sensitivity of this drug. Duration, they often ignored key. If the duration feels too long, it's probably correct because it's months. You have to treat dimorphic fungi organisms for months and not just weeks. So short courses improve symptoms but lead to inevitable relapses. So always treat for a long-term therapy. Full therapy is often necessary to eradicate this low-growing intracellular foci of these fungus. So always go for months to get the treatment as recommendations. Clinical logic, if the patient is severe CNS or immunocompromised infection is there, then go for amphotericin B. If no, then go for azole oral therapy. Step down to azoles if patient is improving with amphotericin B and continue for months for eradication. So common friendly things and the errors that we face is that friendly traits are that for these organisms it has a predictable response curves, extremely low resistance and clear step down pathways are available with the effective oral therapy. All these are friendly tails. But the fatal error that you can do is that stopping azoles early because the patient is asymptomatic. That is the most important thing that you must need to understand. Do not stop therapy for dimorphic fungi within the days of a few days, maybe 10 to 15 days, and then stopping. It's a big blunder. And symptoms resolve long before eradication. So premature cessation leads to relapse, fibrosis, and chronic complications. So always continue azoles for a long term. So final mastery that you must need to know about all these kinds of fungus that we have discussed in all these 7 to 8 modules of videos. That Candida is an yeast with rapidly growing echinocandins are the gold standard therapy initially. Then you can step down to azoles. And for Aspergillus, it is a septate mold with this invasive characteristic. Fluconazole is insensitive to this bug, so you have to go for voriconazole. Mucorales, amphotericin B is the drug of choice because of aseptate mold and it has chaotic angio-invasive properties. Dimorphic is a thermal heat switch. You have to treat with azoles for long term. So if you know this table, you are knowing a lot of antifungal mastery. So keep practicing, and we'll discuss about each of the fungus in detail in upcoming videos in this module. So you don't need to remember any tables, no rote learning, just pure biology. If you remember, everything goes hand in hand. So medicine is such a science. So this is Medicine Beyond Harrison's. If you do like this video, like and subscribe, share it with your friends. Let's see in yet another video. Thank you for watching.